Right. I think the next session is on type 1 diabetes, complications in type 1 diabetes in children. Dr. Tanmoy Chakraborty, who's a pediatrician with a special interest in diabetes. So can you hear us, sir?
I can, yes.
Yes, you can. Okay, so that's good. So, right. So can we have your talk? And
Yes, I'm trying to share my slides. Can you see the slides?
yes, we can. Thank you. Welcome. Guru Prasad wants to say hello.
Tanmoy, hello.
Hello to everyone.
Tanmoy,
Nice to see you all. Guru Prasad and Mridul. We were very contemporary during our college days, and I went to same school with Guru Prasad. Anyway, without much ado, good afternoon to everyone, and you're all welcome to the session here on the complications of type 1 diabetes in children. I'm quite honored and privileged for the invitation from Howrah Town Diabetes Society. I'm not sure how many of you deal with children with diabetes. Is there anyone in audience who have interest in pediatric population?
Dr. Sanjay Shah, as an endocrinologist, I do some work with children, yeah.
Okay, good to know. So after, I believe there must have been some sumptuous lunch in Hyatt, I will try to keep you awake. I hope there will be some interest in this particular population. So I did not cram my presentation with too much of statistics or studies. It is mostly clinical. This is a vast subject to cover really within 20 minutes. But however, I'll try to give you some guidance and to enhance your knowledge. So hoping that it will help in reducing lots of morbidities and mortalities that arise from this condition, especially in this vulnerable group of human beings. I had to do this. No conflict of interest in any of the contents of the presentation. I have used some copyrighted materials, yes, but only for educational purpose. And on the lighter note, I have another declaration. I was in the same batch with a certain person called Sandeep Ghosh in RTKMC, but I have no connections with him anymore. So we can actually divide the complications of type 1 diabetes in children in two categories. One is acute. Some of them come from the disease itself, like diabetic ketoacidosis, and very rarely hyperglycemic hyperosmolar state. And some complications arise from the treatment of the disease, which is obviously hypoglycemia that happens to everyone who gets insulin or even in type 2 diabetes. So there should be much more emphasis on DKA because this is the most common cause of mortality in children. It can happen at the diagnosis and it can happen anytime afterwards, especially when there is lack of insulin delivery or with concurrent serious illness. Just made a synopsis of what you can actually expect if a sick child comes in and you're thinking that there could be DKA, which will be obviously from history. There is no point in reminding you about this, just like polyuria, polydipsia, weight loss, nausea, vomiting. Abdominal pain is quite an unique thing that happens in children. Rapid breathing, shortness of breath, weakness, reduced level of consciousness. On clinical signs, you would get dehydration, sometimes circulatory shock with Kussmaul's breathing, ketone smells, and altered sensorium. But the biochemical establishment of DKA have three components. Obviously, as the name suggests, diabetes, that means hyperglycemia, which is blood glucose more than 11. And I believe in India, we still use the milligram per deciliter, which is over 200 around. Blood gas is an essential part of diagnosing this, where the acidosis we established if the pH is less than 7.3 or bicarbonate less than 18, either or. And ketonemia, so blood ketone has to be 3 or more. If there are not available, then we can still use ketonuria as a component of it, where it has to be moderate to very high. Now, the severity of DKA is established totally on the blood gas. So we consider it mild when the pH is between 7.2 to 7.29 or bicarbonate less than 18. Moderate is 7.1 to 7.19 with the bicarbonate less. I'm not going through everything. So in mild and moderate, we consider the dehydration as 5%. It is not based on the clinical assessment of dehydration. Severe decay is when the pH is less than 7.1 or bicarbonate is less than 5. Then we assume it's 10% dehydration. So once established the diagnosis, then we follow the protocol, or you may say guideline as well. The slide is obviously quite small, but I did put the QR codes. If you can go in there, you can find it easily. And the other one is DKA fluid calculator, because fluid treatment in pediatric DKA, it has come across over decades, a lot of modifications, changes. Now it's established that previously thought less fluid treatment will possibly reduce the incidence of cerebral edema, which is a unique complication in pediatric population with DKA, but it had not shown much of evidence. We are back onto more liberal fluid regimen. If you wish, I can show the complete protocol in a separate slide, but I believe it's not needed with the time constraint. So in key management of DKA, it's standard for any sick person looking after airway, breathing, circulation, and disabilities. The key points to remember is that once you establish the diagnosis, you have to start IV fluid. Do not start the insulin for at least 1 hour. We prefer 1 to 2 hours. After starting the IV fluid, then only we start the insulin. We have to monitor the blood glucose and blood ketone very closely, along with blood gas and electrolytes. We have to be very aware of cerebral edema, because that is a quite unique thing that happens in children, along with hypoglycemia. If you think there is signs of cerebral edema, please treat with mannitol or hypertonic saline. They are all elaborated in that guideline there. Remember to provide potassium in the IV fluid later on. Initial IV fluid bolus to treat the shock or the replenish the initial dehydration doesn't need to be carrying potassium. And after 1 hour or 2 of IV fluid, then you start the insulin with a rate of 0.05 to 0.1 unit per kg per hour. There is another acute complication which has some theoretical knowledge we need to have, which you obviously see much more in adults and in type 2, that is hyperglycemic hyperosmolar state. Unfortunately, this particular condition has got much higher mortality rate than even DKA. Very rarely, DKA and HHS can coexist. But if that happens, the DKA takes priority and we have to treat them as DKA. So I'm not going into the full clinical features of them. They are almost similar to DKA. However, the degree of dehydration is much more, and ketones may or may not be really there. So whenever you're seeing a glucose level of like 600 mg per dl or more, you have to think about the possibility of HHS. And the suspicion goes further high up when you don't find much of hyperketonemia. And acidosis is usually not there. If it is there, it is very mild, and the values are given over there. And the blood or serum osmolality is usually 320 or more, so they are very concentrated. And in comparison to DKA, you see altered consciousness much earlier on. Then we have to obviously talk about hypoglycemia, which is an unavoidable thing that happens to anyone who is on insulin or other anti-hyperglycemic agents. We all know about the manifestations of blood glucose, a low blood glucose, which can manifest in autonomic, neuroglycopenic, and behavioral ways. We teach or educate the patients and their parents telling simple things, which is 4 is the floor. So less than 4 millimoles, which is equivalent to around 70, 72 milligram. Whenever that happens, you have to act quite fast. So there are 3 categories. One is that if the child is cooperative and able to tolerate oral fluids, then we tend to give 10 to 20 gram of fast-acting oral carbohydrate, like some glucose tablets or even Coca-Cola or other sugary drinks is good enough. And we need to check them again in 15 minutes. So we call it a rule of 15. You give 15 grams of glucose and check it in 15 minutes. Sometimes the child can refuse to drink or very uncooperative. Then there is some place of using glucogel or dextrogel. That's a trade name in UK we use. I'm sure there are other substituents in India as well. They are fast-acting sugary gel. So they have around 10 grams of glucose. We squirt them into the mouth and rub into the oral mucosa. So they can be quite absorbed very quickly and act really well. But remember not to use this in an unconscious or fainting child, because there is always a risk of aspiration and failure of treatment. So what happens if a child is unconscious or fainting? The first thing we have to do is to put them in recovery position and assess the airway breathing circulation. We would never try any oral fluid or glucogel. If there is an IV access, then administer IV 10% glucose. Usually we give 3 mils per kg, but can be given up to 5 mils as slow IV bolus. If there is no IV access or the child had the hypoglycemic event at home or somewhere else in school or outside, they always carry a glucagon kit, and that can be given intramuscularly. And then the medical attention needs to be sought quickly. So those are the usual acute complications. Then we move on to the long-term complications. It's not much different from the adult population. We all know about the micro and macrovascular complications that people get from long-term type 1 diabetes. I'm not going into the details of that. You are all aware of the problems. I would put my focus on how often and when we should start screening these children who has type 1 diabetes. So usually for retinopathy, neuropathy, and macrovascular disease, we start them at around 11 years of age. If they had 2 to 5 years of history of diabetes. If they are older, then they get that straight away on the first time. For nephropathy, we take either puberty as the start of doing the screening, or earlier if they have diagnosed with diabetes before 11 years of age and had a history of 2 to 5 years. Now, screening methods are also not very different. We do urinary albumin-creatinine ratio, and the frequency is usually annually, or if there are any queries of increased albumin in urine, then we may have to do it earlier on. Quick tip about that, in adolescent males, we usually ask them not to masturbate at least 12 hours before giving the morning sample, because sometimes it can give us spurious results. For retinopathy, they get the fundus examined, usually by an ophthalmologist, and retinal photography is taken. It happens every 2 to 3 years, but annually we do, within the clinic, we do direct ophthalmoscopy. Neuropathy is based on, obviously, history and physical examinations, checking their peripheral neuropathy signs. And for macrovascular disease, we check their BP on every clinic, which is every 3 months. And we check the lipid panels every 3 years. That is the International Society for Pediatric Endocrinology and Diabetes, their recommendation. But in UK, they get it done every year rather than 3 years. There's a diagram which shows the algorithms for whenever we get the urine ACR high, what to do next. Because it's not only just the screening, if we come across the possibility of problems, how to go forward. I was listening to Dr. Ambar Bashu's presentation just a few minutes ago. Obviously, in pediatric population, we have no rule established yet for SGLT2 inhibitors. We still use the ACE inhibitors or ARBs rarely. Now, there are a lot of other complications and more importantly, some associated conditions that happen more frequently in children with type 1 diabetes than general population. The first thing we should monitor them is their growth, weight gain, and pubertal development. Obviously, we all know that poor glycemic control leads to suboptimal growth and delayed puberty. There is also, in girls, there is a risk of delayed menarche and menstrual irregularities together with hyperandrogenism. It has got no role with glycemic management. We still are in dark why this happens. There must be some quite complicated pathophysiology behind it, but the percentage of them is really small. We should mention about a problem called Mauriac syndrome, which is characterized by growth failure, hepatomegaly, glycogenic hepatopathy, and steatosis, and also pubertal delay. This is a very uncommon complication, and sometimes we had to encounter that if there are concomitant eating disorders like anorexia nervosa. The other associated autoimmune conditions, as you know, are quite common with type 1 diabetes. So these are the more common things that can happen. But the first two that are highlighted in red is Hashimoto's thyroiditis and celiac disease. Obviously, in Western population, the incidence of celiac disease is much higher than India. But I believe in India, celiac is also growing, especially in northern part of India, where wheat is more staple in the diet than rice. I believe in Bengal, we probably don't encounter that too much. Along with that, obviously, hyperthyroidism is there. Addison's disease can happen, autoimmune gastritis. Occurrence of that in pediatric population is very, very small. I haven't come across any in last 17 years. And other systemic autoimmune disease can happen, like juvenile idiopathic arthritis, Sjogren syndrome, psoriasis, sarcoidosis. I believe I have come across 1 or 2 GIA, but have not seen the others. So for all of these other autoimmune conditions, 2 of them, the Hashimoto's thyroiditis and celiac, they need regular screening. And the way it is done is elaborated on this slide. I'll give you a little bit of time to go through that. All right. Now, there is an array of skin conditions that can happen with type 1 diabetes. We'll go through them by name only.
Dr.
But
Dr. Bhattacharya,
yes.
five more minutes. Chakraborty, 5 more minutes, please. Yeah.
Yep, okay. So there are some novel conditions that are happening these days because we are using more of insulin pumps. Around 80% of my cohort of pediatric diabetes, they are on pump and CGM. So they are coming up with some skin conditions, mostly related to the adhesive and continuous frictions, allergic stuff. So that's a completely different chapter. We all know about insulin-induced lipodystrophy. In children, we see more of lipohypertrophy than atrophy. We all know about them. It's very important to screen for them and give them the preventative measures. And that's all we can do at this point. One thing we may remember that for CGM, we can still use the lipohypertrophic areas, but for the pump or injections, we definitely cannot. And there is an entity called insulin edema, which is very rare. It happens initially within first couple of weeks of starting insulin treatment, but they get better with reduction of insulin dose. Vitiligo can happen as an associated condition, and lots of other conditions that are common in type 1, like recurrent infection, and the names are all there, but they are thankfully rare in children. There are a couple of other novel complications. One is called limited joint mobility of childhood diabetes, which is rare. It usually happens on the proximal metacarpophalangeal joint of the little finger and then spreads distally. It's not painful. And if it is there, we have to remember we have to look for macrovascular complications. And treatment-induced neuropathy of diabetes, which is thankfully very rare, previously known as insulin neuritis. It's a self-limiting condition, gets better with a few weeks' time with insulin dose reduction. So I source my information from these guidelines of International Society and British Society of Pediatric Diabetes. Any questions you may have?
Thank you for that overview, honestly. And personally, I have a question because there are times when I sort of also have faced this, though those are adolescent patients. They seem to, while treating their DKA, I don't know, is it because mismanaged fluid management or insulin doses, from HHS to DKA and from DKA to HHS in the same admission? Have you sort of seen that kind of situation while treating the odd patient with hyperglycemic state in children? Any comments on that?
I have come across only one HHS, and they thankfully didn't have DKA at the same time.
Okay.
But I believe in our setup in UK, we are very much protocol oriented, and people seem to get senior advice very quickly.
Okay.
So passing the buck on, they don't try any misadventure or anything. So no, I would say complication-wise, I haven't come across with this.
Fair enough. Because I always felt that the couple of times that I saw, perhaps it's either the inadequate insulinization or the inadequate mismanaged fluid management. It seemed as if the patient moved from diabetic ketoacidosis to hyperglycemic state, and then from hyperglycemic state they went to ketoacidosis in the same admission, in the same bed over the next few days.
I think there is a generalized fear of over-treating the DKA.
Yeah.
So people tend to deliver less insulin.
Yeah.
And actually in the protocols, it says you have to, as long as the ketones are there, you have to give them insulin. And if needed, add on dextrose into the IV fluid to maintain a normal range of glucose.
Absolutely. The other condition you talked about was insulin-treated neuropathy. I presume this is nothing but a form of mononeuritis, which is transient and it just recovers. Is that the thought behind it?
Yeah, it usually previously called insulin neuritis. Now that they changed the name, it comes in as like burning, stabbing, pain, and it happens. It's not a mononeuritis. It can usually comes in the form of polyneuritis peripherally. But It's basically the neurons, they react quite oddly when they were quite habituated in a very high glycemic condition. All of a sudden, with insulin treatment, they got deprived from sugar.
Okay.
That's why they get the inflammation. It usually gets better within 2 to 3 weeks, but you have to reduce the insulin dose to get their glycemic state bit on the higher level.
Okay.
So slower acclimatization. It is usually self-limiting,
Yeah, so
but can be quite painful.
Yeah, okay. So slower acclimatization is the key.
Is the key,
What
yeah.
drives this thing. Right, thank you, thank you. Any questions from the floor? Guru, yourself?
The pathophysiology looks like aggravation of diabetic retinopathy with the control or reduction of glycemia. Is it?
Sorry, can you say that again?
The pathophysiology is akin to the aggravation of diabetic retinopathy with sharp reduction of blood glucose levels.
Yeah.
Like that. Okay.
Yeah, yeah.
Thank you, Tanmoy. It's nice to hear from you and seeing you online after a couple of years. And you have done very good in type 1 diabetes. I have no scope in my practice to exercise on type 1 diabetes, but I love to treat type 2 diabetic patients. Thank you. I will contact you again.
Thank you, Dr. Chakraborty, for that wonderful presentation. And I think we'll perhaps next time we will connect with you because I think this is a very nice session with respect to type 1 diabetes. Thank you very much. Bye-bye.
Thank you. We'll love to. Bye.
তন্ময়, তোকে তো এখান থেকে ফেলিসিটেশন করা যাবে না, অনলাইন ফেলিসিটেশন করলাম।
No problem. I'll be there.
যখন আসবি অবশ্যই দেখা করবি। দেখ, গুরুপ্রসাদ এবং ডক্টর শাহ একটা করে কোট পরে আছে, তোর জন্যও রাখা আছে। তুই যখন আসবি তখন পাবি, অবশ্যই দেখা করবি।
Sure.
ওকে, বাই, থ্যাংক ইউ।
Bye.